All right. Good morning. Hope you guys are having a good day. What I'm going to start with today is barbiturates. This actually is what made me start doing anesthesia. The first case I ever saw actually involved using sodium thiopental as the induction agent. And once I actually saw how this medication worked, I was like so impressed. That's going to be I'm going to do it for the rest of my life. And that's what I ended up doing. So barbiturates is something that is more of a historical discussion right now because pretty much they've been taken off the market. But I think it's important for you to understand some of these medications and how they work. As they might come back in the future, who knows? So let's just talk about barbiturates today first. First of all, we'll talk about commercial preparations. We'll talk about some structure-activity relationships, which I found that they're putting now on your boards. They're actually showing you chemical structures and expecting you to understand what they do. Mechanisms of action, pharmacokinetics, clinical indications, and side effects. Now, there's basically three commercial preparations, or three main ultra-short barbiturates that we end up using in clinical. Okay? And most of these in the past were used. The two major ones was thiopental and methylhexatol, and each one had their major application. About 90% I said maybe 98% of all inductions were done by using sodium thiopental before 1986, before the introduction of propofol. Propofol rapidly took over as a major induction agent because it's actually a much better agent. And we'll talk about that next week some more. But thiopental was actually very, very useful from the 1930s, 1920s, all the way to 1986. So it had a pretty good long run of about 45, 50 years. Thiopental was the major agent that was used during World War II for induction. It was found to be very safe once they realized what the problems with it were. There's some anecdotal conversations that people say that during Pearl Harbor, more Navy personnel died on induction of anesthesia than they were killed by the Japanese. And that might have been true because they were giving this agent in patients that are in shock. But once they realized that they had to reduce the dosage, then it became safe again. Now, the way these medications come is they're prepared in sodium salts that are very highly alkaline. Okay? And that puts them in suspension. When you actually get sodium thiopental, it's actually in a crystallized form. You don't ever use it. You don't reconstitute it until you're ready to use it. Okay? Thiopental in the 1940s, 1950s would come as a single vial, and the pharmacist would actually, or somebody in the OR would actually make one bag, and then everybody would draw it from that bag, and you would use it. In the VA system where I first started working as a resident, we had just one bag that was prepared for us, brought in, and everybody would draw it off to a stopcock and then have their sodium thiopental. So it was very, very cheap. Okay? The other way it actually comes is as a syringe with two components. One is it's a glass component that has all the crystals inside of it, and then you hook it up to your actual dispensing device, and then you draw the saline into it, and then you have it now reconstituted, and it works very, very well. The actual pH of the solution is around it's a 2.5% solution. The pH of it is around 10.5. So you can imagine these medications, when you inject them, they're not going to feel very good. They do burn. Okay? Just like acidics burn, alkalines burn. People are not going to feel comfortable with it. So one of the things that you learn when using this medication is that you try to get a large bore IV before you properly injected it. Thiopental, also known as sodium pentothal or thiopental sodium. You also have thioamylol. Thioamylol comes as thioamylol sodium. The 1% solution comes also at a pH of 10.5 for methylhexatol. Methylhexatol is also a barbiturate. It is used in certain situations that are very specific, which we'll show you here in a few minutes. And it's actually a very useful agent if you use it within that constraints. And that barbiturate is still being used. This is one. Thiopental has actually been taken off the market. Not because it's a bad drug, because the actual producer of it, which is in Italy, they got a lot of protest because in the United States, the main medication that's used to put people to sleep permanently is initiating dose is sodium thiopental. So they actually caused them enough ruckus that it was said it's not worth us keeping this stuff to be produced, so they closed down the factory. So it means the rest of the world is now suffering from it. Besides, sodium thiopental is a very useful agent for third world countries. Sodium salts are incompatible with acidic solutions like opiates, catecholamines, and neuromuscular blockers. So one of the problems that when you injected this medication is that you had to inject it quickly, then wait a few seconds, follow it with your muscle relaxants or your opiates. If you didn't, you would see this white kind of stuff appear all in your IV line. And you're sort of stuck at that point because you had to give it. But it was actually you're sending crystals downstream, which is something you really don't want to do. Okay? When you crystallize it, of course, what happens to the solution? What happens to the potency of the medication? It doesn't work. Okay? So something you got to be aware of. So now this is the actual different kinds of barbiturates that are available. They're usually broken down clinically, at least when I was learning, into 4 major groups. They were called the long-acting, medium-acting, short-acting, and the very short-acting. Okay? This is really an artifact in the sense of it tells you the duration of action of a single dose. Okay? It doesn't talk about repetitive doses. One of the things that I was taught to do one time was we were just discussing it with one of my attendings about how to deliver anesthesia a little bit differently, and asked them, well, did you guys ever give thiopental by it's a sole agent? And one of my attendings who was a World War II, but he was in the Korean War, and he was also in the Vietnam War. He told me, he said, oh, we used to give thiopental drips in people and keep them asleep. And we're like, really? You actually can do that? So I said, well, guess what? You get to do that today. So I got to go back and read up on the book and actually did a thiopental drip anesthetic. It doesn't work very well because it actually will accumulate tremendously on you when you start giving it IV. And that's really the downside to these agents. Okay? So they're really great for one-shot dose, but they're really bad when you start putting them on as a continuous IV drips. Versus propofol doesn't do that. The accumulation rate on these medications are pretty high. So even though you call this short-acting or very short-acting, within a short period of time of putting something in a drip, they become very long-acting. They saturate into the fat tissue pretty rapidly and makes them ineffective as a short-acting agent. Now the structure relationships, classifications of barbiturates as long, intermediate, and short-acting may be misleading, as I just explained to you. The administration of an ultra-short-acting barbiturate results in a residual drug in the body after the initial effect has worn off. The main reason that these medications wear off is because of redistribution. That's really the important take-home point. This is where really anesthesia began to learn that medications that can redistribute rapidly can actually be very helpful. Okay? Because if you can get something to go in quick and it work, but also comes off quick, has a lot of benefits. The downside to barbiturates is that they're extensively metabolized, and they take a long time to come off. We'll show you that in a minute. Administration of one of more drug can result in converting an ultra-short-acting barbiturate into a long-acting barbiturate, like I explained to you before. And long after the desired effect is gone, the patient may actually have a hangover effect, which is really why this medication's gone away. Or at least clinically, we don't use it as much. I wish I still had it around because there's certain reasons that I actually want to have it for use, but now we can't find it. The federal government has now taken all the sodium thiopental that they have and stored it away so they could continue doing what they need to do. And but it maintains a decreased psychomotor function for a long period of time. People that got sodium thiopental, even a single dose, some people would actually take up to 3 to 4 days to feel it back to being normal again. So it was pretty impressive stuff. the way it actually will penetrate into the fat and then come back out slowly. Now, way all barbiturates are made is they're made from urea and malonic acid. This is the actual compounds that you see. The book doesn't do that good a job. I'll try to show you a little bit better description of it. And what this will actually do is that it binds together by a hydrolysis reaction, so it loses water. And it combines the actual OH to this. So the OH peels off. So you have two water molecules that you lose, and you lose a hydrogen, of course, on this side, one hydrogen, one hydrogen. So, and then you get all the barbiturate acid as your main component. You're going to see repetitively, one of the things that I want you to understand when you look at barbiturates and benzodiazepines, is that you can have a very common structure, which is not quite the benzene ring, but basically a cyclic structure. Okay? You're going to see this repetitively. These cyclic structures are where actually can bind nicely onto a receptor site. So you'll see this repetitively as we show you different medications. Now, sedative hypnotic properties can be added to that barbiturate ring by adding a number 2 and number 5 carbon atoms. So right here, number 2 and number 5. The thiopental, thio means sulfur. So anytime you see a medication that says thio on it, it means that it has sulfur compound on it. And there's actually two subclassifications of barbiturates: the thiobarbiturates and the oxybarbiturates. The thiobarbiturates are the ones that have, of course, in the number 2 group, the sulfur, and the oxybarbiturates, which you see here, which is what methohexatol is. You can see the oxygen isn't actually hooked up to group number 2 on your carbon ring. If you add branch chain substituents to carbon 5, you actually increase the hypnotic effects of the medication. So you're actually improving the binding site and causing hypnosis in these individuals. And phenol groups, which is like right here, which you see down here, which is phenobarbital. That's why it's got the first part of it is pheno, which is equivalent to the phenol. You'll see that a lot of times in pharmacological descriptions of drugs, not the trade name, but the generic name, usually comes from something chemically structural about that medication. And we'll show that as well with benzodiazepine. But when you add a phenol group, you increase the anticonvulsive activity of the medication. And phenobarbital continues and is a very effective anticonvulsant. If you add a methyl radical, which is up here, which is a CH3 group, it actually confers convulsive activity to that medication. So you have two possible properties on a barbiturate. You can actually stop seizures or initiate them. So you go like, why would I want to have a drug that causes seizures? That's really not a good idea, right? And you would say most of the time in clinical situations you don't. But methohexatol is one of the primary drugs that we use for psychiatric treatment of patients for what's called ECT, which is electroconvulsive therapy. We actually want to induce seizures. And one of the problems that we would have in the old days is that when we began to induce medications, like give sodium thiopental to somebody, or thioamylol, which is also a short-acting, you would suppress the seizures, and then the treatment would be ineffective. And instead, it was found that if you use methohexatol, you actually increase the seizure activity and get a much better treatment effect, because you actually want to induce the seizures in that situation. So methohexatol is really the only barbiturate that we pretty much use clinically that has convulsive activity. Now, the two structural families, again, are oxybarbiturates and the thiobarbiturates. The oxybarbiturates are the barbiturates with an oxygen atom and carbon 2, and the thio replacement of oxygen with sulfur atom, which is thiopental and thioamylol. The addition of sulfur adds significant lipid solubility. So it has a much greater hypnotic effect. It's much faster. And the other thing is, because it's so lipid soluble, it comes on and comes off. So it goes into the brain quickly, which is the way I think of the brain is just a huge fat globule, okay? And it just gets in very rapidly, and then because there's so much blood flow going to the brain, it can redistribute very quickly as well. Now, how the actual medication works is it binds to GABA. This is the discussion today. You really have to understand GABA today. When we talk about benzodiazepines, they work here as well. But GABA is kind of interesting. The GABA receptor is kind of interesting because it doesn't have just one site. It has multiple sites on its surface that can bind to different medications. And some of the actual sites, when they work together, which means two different sites are bound by two different drugs, they will have a significant synergistic effect. Okay? What basically, anytime you have a GABA agonist activity, you're going to cause a sedative hypnotic effect on the individual. You're going to suppress their central nervous system and make them fall asleep. Now, if you've never seen sodium thiopental work, it actually is very impressive. It's much more impressive than putting somebody to sleep with propofol. Propofol is a little bit more gentle the way it puts you to sleep. Pentothal is like you're there, and then the next thing, you're gone. You're completely gone. You know? And it's like you look at yourself like, wow, that was really fast. 30 seconds or less. It's just a matter of how much time the bloodstream got IV injected till it got to the brain. And it was very, very reliable. You could actually put your watch on it, okay? And you can actually figure out from it how good the cardiac output was. Okay? And a lot of us would actually put our time clocks and press it as soon as we give it the thiopental, because it would tell us how fast the bloodstream was moving from the IV to the brain. Diprovan's a little bit delayed. Even though it hits air pretty quick, it's about 10 seconds behind thiopental. Thiopental is amazingly fast. So if you ever get a chance to put somebody to sleep with thiopental, at least one time, you should see the difference. The downside to it, of course, is that it has that prolonged effect, but it's a pretty impressive medication. When you bind to GABA receptors, you basically increase the main electrolyte that passes through GABA is chloride. Chloride, so this is a chloride channel, not a sodium channel, but actually a chloride channel. So this is a negative charged molecule that passes into the nerve once the agent binds to this receptor. So, and when that happens, the chloride increases the negative potential inside the cell that you're doing that to. Well, when you cause negative potential, the resting membrane potential is going to become more negative. So it's going to make it more difficult to hit threshold. So it's going to suppress that activity. It's going to make that person's nervous system be more resistant to activity that would wake them up. Right? Now, these GABA receptors are pretty potent, and they have very different densities around the brain, and I'll show you that in a little bit as well. But most of the mechanism that you're looking at here is hyperpolarization by the chloride changes. They also appear to decrease the dissociation of GABA from receptors. So when you give somebody a benzodiazepine, not only does it act like an agonist, but it's synergistic. It basically adds to a natural effect of GABA agents. So one of the things that we would notice is that when GABA receptors are really stimulated more is when? Right now you're pretty awake, right? At least most of you. Okay? But early this morning, you were about 4 o'clock in the morning, most of you were sleeping. Okay? What was keeping you asleep is that you have GABA activation. Okay? So you have more GABA agonists in your bloodstream or in your brain at that point. If you give somebody sodium thiopental late at night, okay, what do you think they're going to be like to try to wake up? It's going to be more difficult because it acts synergistically when you have higher GABA counts. So one of the things that we would notice is like if we were putting somebody to sleep late at night, and you gave them thiopentol, you would have a long time to try to wake them up. They'd just like, come on, wake up, and you just couldn't get them to wake up, even though it's a short-acting drug. So it can act very synergistically that way. And actually, you can look at the cycles of the day. If you just look at your emergence times comparison-wise, and you would do cases early in the morning when people were already, the GABA receptors were being deactivated and trying to drive you to wake up, putting the peripheral to sleep would have you have a rapid awakening afterwards. But later in the day, by the time it got to be later, like late in the evening, you started doing cases, then you notice that people were harder and harder to wake up. It's that synergistic action that you're seeing. Okay. This is a nice picture. I've just never seen this before. I just found this on the web. This is a nice picture showing you the actual GABA receptors in the postsynaptic neuron, and how by release of a presynaptic neuron by the actual GABA receptor, it actually causes more chloride to be deposited, causing it more negative charge inside the cell. GABA is just a normal endogenous neurotransmitter that you produce. Benzodiazepines and barbiturates, as well as alcohol, and many other things, by the way, will have affinity to this receptor and cause you to be sedated and take away anxiety. It uniquely depresses the reticular activating system of the brain. That's the area of the brain that's responsible for you to wake up. It increases your brain activity. It also depresses the transmission of sympathetic nervous system ganglia. So all barbiturates are venodilators. So they're preload reducers. Okay? And that's really the most important concept you got away with if you using barbiturates. If you're using these agents, you're going to cause venodilation, and you're going to cause a preload reduction. If you are on the high end of preload, which is you're in congestive heart failure, this medication may actually be helpful. But where the danger is when you're taking somebody that's in shock and you give this medication to them. You give somebody thiopentol in shock, you'll see a complete cardiovascular collapse and death. So you got to be really, really careful. Your induction dose goes way down, almost by 50% when you put these people to sleep. Normally, if you have a normal, intact volume in your body, pentothal drops your blood pressure maybe about 15 to 20%. It's not a big deal. Something you can easily manage. It's not that's going to cause a cardiovascular collapse on you every time. At high doses, it decreases the sensitivity of postsynaptic membrane to acetylcholine. So it actually begins to inhibit acetylcholine binding to the acetylcholine receptors. So it actually enhances muscle relaxation. But I can promise you that we never use sodium pentothal as a muscle relaxant. You just can't give enough of it. Okay? If you give that much of a high dose, you're going to cause the person never to wake up. Okay? And one of the downsides of barbiturates, and the reason that we went away from it as well, is that when you try to put an LMA in somebody with sodium pentothal, you're asking for it. You're going to be in so much trouble. Diprovan is a beautiful drug because it actually will suppress laryngeal reflexes so much so that you can actually intubate somebody just with Diprovan and not see much vocal cord movement. When you gave sodium pentothal, the person would be asleep very fast, but it would not be deep enough. It didn't have the density that Diprovan does. And when you put the laryngoscope in those individuals, you'll see the vocal cords would close and you get actually laryngospasm. So if you try to put an LMA in somebody with sodium pentothal, and trust me, I tried for about 2 years. I kept being told that LMAs are these great new things, and I wanted to use them, and I had a whole stack of them sitting on my anesthesia desk at work, and I couldn't use any of it. Every time I tried, it was a disaster. And as a resident, we actually called the guy that was the manufacturer and asked him, can you tell us what we're doing wrong? And he came all the way from England, and he came and saw us and walked into the OR and says, what are you guys doing? He says, well, we're going to give sodium pentothal as our induction agent. And he says, where's your Diprovan? And I'm going like, what? What's Diprovan? We didn't even know what it was. It wasn't even in our country yet. And he says, well, you can't use this stuff. It won't work. So okay. So we had the whole stack, but we had to wait till the Diprovan came in, which came in about 2 years later. And then we were only allowed to use Diprovan just because it's so expensive for induction for patients that we need to put LMAs in. And that way we did work. So there is some muscle relaxation, but the book over describes it. It was never really effective in suppressing muscle relaxation enough to do surgical procedures. And that's why they developed curare and succinylcholine, mostly curare, because you couldn't get enough depth of muscle relaxation in these individuals. If you look at the pharmacokinetics, the most important thing is that it's a very rapid onset. Okay? So it has very rapid effect site equilibration. It's actually one of the most rapid medications to see the effect, and of course the effect site is the brain. But what actually terminates the action is that it redistributes just as fast as it comes on. When you gave a single dose of sodium thiopental, you could pretty be much assured that in 7.5 minutes, the person will be beginning to stir. Not be awake, but beginning to breathe and rouse. Okay? The first 4 minutes or 3 minutes after you gave that medication, they're really not breathing. Okay? But before that, after that, they start trying to move around pretty quick. So it does give you a prompt awakening after a single dose of thiopental, thiamalol, or methotrexate. The elimination is entirely dependent on metabolism, and that's really one of the downfalls of barbiturates, is that they really are very heavily metabolized. Almost 99% of it is metabolized, and only 1% is actually excreted through the urine unchanged. When you look at context-sensitive half-times, when you give medications repetitively, these drugs don't have a good profile. Okay? These are the drugs when you give repetitively, you get a lot of sequestration in the fat and skeletal muscle, and these depot sites basically allow the barbiturate to come back into your bloodstream and keep you asleep for a prolonged period of time. Now, because they're also lipid soluble, they're also highly protein bound. Okay? So it comes together. Now, of course, these are the medications that require basically a carrier to walk them around. Okay? The high protein binding keeps them from being active until they distribute out into the brain. If you don't have enough protein in your body, the actual medication effect is going to actually increase. So the potency increases. So barbiturates are very dangerous in patients that have liver problems, where they're not producing albumin, patients that are nutritionally depleted like cancer patients that have chronic renal failure, where they begin to spill all the protein out of their urine. All those people have a much higher increased risk of developing overdosages when you give these medications. And you've got to take that into consideration. Now, the lipid solubility is determined by its non-ionized part. Okay? Remember, when you're initially making the solution, IV, okay, you want the medication to stay crystallized. So you drive it into a high pH to make it ionized. When it gets into your bloodstream, it immediately converts back into its unionized state. Okay? Once it goes into its unionized state, it tries to bind immediately to protein to be carried around. Okay? The ionized molecule has very poor lipid solubility. So you want the medication to be non-ionized to actually have the effect that you want. So increased lipid solubility, increased protein binding, as you'll see repetitively talked about today. Thiobarbiturates are more protein bound than the oxybarbiturates because they have greater ability to stay unionized. Thiopental has the highest protein binding. We look at about 86% of the sodium thiopental is bound to albumin, which is pretty impressive. So enhanced effects can occur from decreased protein binding due to displacement by other drugs. So you have to be also aware of that all the time. You always have to look at if there's any other profile, any drug profile that would cause an overdose effect, aspirin and phenylbutazone. Or you have decreased protein binding due to displacement by metabolites such as uremia and nitrogenous waste. Or you have decreased protein binding due to lack of protein production like cirrhosis. Now, distribution is determined basically, of course, by lipid solubility, which is the most important, followed by protein binding, ionization, and tissue blood flow. And one of the things that we notice that if the patient's hypovolemic, it may decrease the blood to the skeletal muscles while the blood flow to the brain and heart is still maintained. You tend to get an overdose, so you get an exaggerated cerebral and cardiac depression effect with these medications, which is what you saw in shock. Remember, you vasoconstrict peripherally as you get into shock states. If you get into a very profound shock, you will get even a decrease in blood flow to the skeletal muscles. Now, the effect site equilibration is very, very rapid. Like I said before, it's about 30 seconds. Thiopental, thiamidol, and methotrexate undergo maximal uptake, brain uptake, and that's why they're called ultra-short acting. The brain receives 10% of the total dose in the first 30 or 40 seconds. So you're really not getting a huge wallop of medication. What that basically means that you're giving a 90% overdose. All right. 10% of the medication is actually getting there. The other 90% stays bound to a protein and doesn't really expose it to the brain. Now, why is that important? Okay? Any medication that you're giving like that, if you change the carrier state, it's binding to it, just by a little bit, it can have profound effects on the actual, it goes into the toxicity range very quickly. If you give somebody a dose of, say, that only gets 10%, if you get 5% less binding, or to say 10% less binding, you have basically increased the medication by 100%. So that's pretty impressive. That can really hurt somebody pretty quick. And the toxicity range can be narrow in some of these medications. Redistribution is one of the good things about this medication, but if you cause profound shock in somebody, what happens to redistribution? It stops. It won't go out. Okay? If you stop blood flow to the brain, it's going to stay in the brain, and it's going to keep you suppressed. So you need that blood flow to the vessel-rich groups to pull away the barbiturate back out. Okay? But it's the redistribution is by far the single most important mechanism for early awakening. It's not metabolism, it's not elimination, it's redistribution. Over and over again, they'll ask you that in exams. Skeletal muscle is one of the areas where this stuff goes. Skeletal muscle is the most prominent site for initial distribution of the highly lipid-soluble barbiturates, or like my British colleagues would say, barbiturates, which I call it barbiturates. I'm sorry, the American. Initial decrease in plasma concentration is due to uptake of the drug in skeletal muscle, and equilibrium with skeletal muscle is reached within 15 minutes. So that's the second compartment it fills. And then the next compartment it goes to is fat. Equilibration is, like I said, in 15 minutes. If you need to decrease the dosage with decreased muscle mass, so people that are elderly and nutritionally depleted won't absorb the drug very well, and as a consequence will stay high in the blood plasma levels and get an overdose. Or you have situations where you get shock states where you actually have decreased skeletal blood flow, will also not redistribute the medication properly, and you'll get a prolonged effect. Now, eventually it redistributes into the fat. Fat is the only compartment which concentrations of thiopental continue to increase 30 minutes after administration. So this is where the downside is. If you're putting to sleep somebody who is morbidly obese with thiopental, and what you usually do with your dose is you increase it based on mass. It should be lean body mass, but a lot of people forgot that, and they would give it to total body mass. And what would happen is the medication would then go to the fat and sit there, and these people would basically take a long time to wake up. So when you give these medications, if you end up ever using them, use the lean body mass. That's only what you care about because that's what's going to bind to the brain. If you use total body mass, now you're going to saturate all the compartments. It's not going to give you the effect that you want. Thiopental has a fat blood partition coefficient of 11, so that's pretty impressive, at least for an IV medication it is. It will continue moving to fat as long as the blood concentration is 11 times the fat concentration, less than 11 times the fat concentration. With repeated doses, salpental fat becomes a reservoir for maintaining the plasma concentrations, and eventually will saturate. Okay? And so really use your lean body mass for lean body weight to actually give this medication. If you look at the effects of ionization, the pKa of salpental, which is 7.6, is near the pH of blood. That's kind of nice because then 50% of the medication is ionized versus ionized. But remember, what's the solution when you start with? 10.5. So that's the ionized fraction. And it's driving into an ionic state. Okay? But when you bring it back to 7.4 pH, the pKa will help you drive that medication into more of a non-ionized state, which then has a greater lipid solubility and greater effect. If you make the person more acidotic, it favors the non-ionized state. Okay? And that's kind of a dangerous thing, too. If you're in a situation where you're in shock, you're hypovolemic, what are you going to be also? You're going to have a metabolic acidosis a lot of times because you're in profound shock. So when you gave this medication, it would go more into its non-ionized state and it have a greater potency of effect. And you had to take that into consideration as well. If, on the other hand, you're alkalotic, which is almost never happens, okay, it decreases the CNS activity. You know, I've never, I can't say never, but the times that I've actually put somebody to sleep that's alkalotic is pretty rare. Okay? So, but the acidosis actually was pretty common. Metabolism will induce alterations in pH changes, a greater effects on drug distribution and changes due to respiration. So, and why does that happen? Why is the metabolism so much more important? Is the metabolic effects don't really change the CNS right away. They take time. They delay behind it. So as a consequence, the medication goes in. It now converts into a non-ionized possible charge, and then it doesn't want to come out, and then it stays as a depot in the brain. So you have a much prolonged effect. Versus somebody with respiratory changes, the pH normalizes in both compartments more rapidly because the respiratory acidosis or respiratory pH changes are due to what? Carbon dioxide, right? So carbon dioxide transfers across the blood-brain barrier rather easily. So it alters the pH in the central nervous system very easily. Versus metabolic acidosis doesn't really cross the blood-brain barrier very easily at all. It takes its time. Okay? Metabolism is extensive. Barbiturates are metabolized extensively by the liver and also by extrahepatic sites, including the kidney. Oxybarbiturates, on the other hand, are completely converted, metabolized by the hepatocytes only. Okay? So just anytime you add thiol groups to it, you tend to make more tissue to be able to break it down. The reserve capacity, of course, of the liver is huge, and so it takes a lot of hepatic dysfunction before you see the prolonged effects of barbiturates. Salpental, let's go into that first. Distribution is really the most important part that determines the action of the medication. And then the after effects, the prolonged, I feel drowsy, tired, depends on your metabolism. Some people are very rapid at using their P450 system. This is where we began to understand how P450s worked. I mean, the big question after you give sodium salpental was some patients, they would wake up like it was nothing. And when you talk to those patients, they were alcoholics, okay? They were drinking a lot, or they were also taking other drugs at home for sleeping medications. There were barbiturates or benzodiazepines that would crank up the P450 system more so from the barbiturates. And as a consequence, these people, when you put them to sleep, they would redistribute quickly, but they wouldn't have the lingering effects because their P450 would wash them out. It was the people that basically lived a perfect life. They never did anything wrong, didn't drink, and you give them sodium salpental, it was like hitting them with a Mack truck, okay? And they would stay asleep for almost hours afterwards. So the P450 system is really critical in the degree of breakdown of these medications. Low hepatic extraction ratios, which is low metabolism, is part of this. You get metabolism dependent on hepatic enzyme activity. It's not really affected by hepatic blood flow. And a certain degree of thiopental's metabolism is extrahepatic because it's a thioid group. Liver effects do not prolong metabolism because the acute enzyme induction inhibition does not modify duration of action under most circumstances, but you do see that effect in different individuals. You do see problems when patients have cirrhosis. Okay? Clearance is not any different than in normal patients is if you have cirrhosis in these individuals because you have the extrahepatic functions. So when we talk about the oxybarbiturates, you see that that's different. Chronic enzyme induction from chronic exposure of pollutants may explain the increase in dose requirement in urban patients. So also if you have alcoholics, you have to increase your dosage if you want to have a prolonged effect. Methotrexate, on the other hand, methotrexate, remember, it's an oxybarbiturate. Methotrexate still remains dependent upon redistribution, just like all the other barbiturates. It's ultra-short acting. Metabolism actually is more important than redistribution and termination of the psychomotor functions. Methotrexate is actually metabolized more rapidly than thiopental, and it has a lesser lipid solubility, so that helps keep it remains in the plasma to become available for metabolism, which is kind of good. Hepatic clearance of methotrexate is 3 to 4 times greater than actual thiopental. Methotrexate has, unfortunately, when you keep it around, has many psychomotor functions, but they do recover faster than with thiopental because of the liver. Recovery from methotrexate is more predictable after repeated doses and is more dependent on cardiac output and hepatic blood flow. Barbiturates is methotrexate. Renal excretion-wise, how you get rid of it? Thiopental, thiamidol, and methotrexate have a high degree of protein binding, which limits the filtration by the kidney. And also, one of the downsides to it is you can't dialyze this stuff off. And they're so highly lipid soluble that they come right back in, even though you can possibly filter them at times. But the first problem is you can't filter them through a dialysis machine, and you can't filter them through the glomerulus. And also, if you do get it passed into the renal tubule, because of its high lipid solubility, it comes right back through and gets back into the bloodstream. So less than 1% of the actual intact medication is excreted through the urine. It's a very small percent. Phenobarbital has a little bit, which is a longer-acting agent, has a lower protein binding and has a little bit lower lipid solubility. So it does have significant renal excretion in the unchanged form. Renal excretion may actually be increased by alkalinizing the urine. And one of the things that we'll do is if you have a phenobarbital overdose, you'll actually alkalinize the urine to try to pull that medication out. Now, your elimination half-time for thiopental and methotrexate tend to be a little bit similar. They have slow distribution half-times, and the volume distribution is large in both of these. They differ in their rapid distribution half-time, elimination half-time, and clearance. And what I've done for you here in this box is to show you the difference in time. The red ones are the ones that are different. If you look at the green ones, which are the ones that are the same, the distribution half-times are around 62 minutes or 60 minutes, which is pretty similar. And the volume distribution is around the same, about 2.5 to 2.2 liters per kilogram. The actual this rapid distribution half-time is actually much faster, a little bit faster with methotrexate in comparison to thiopental, and your elimination half-times and clearances are a little faster for methotrexate, elimination half-time, and your clearance is actually a little bit faster with thiopental. Your elimination half-time is you have to take into consideration the patients that you're taking care of. If you're looking at pediatric patients, the elimination half-time for thiopental is shortened due to increase in hepatic clearance in pediatric patients, making recovery actually more rapid after repeated doses, and that's kind of a good thing. As you increase the age, though, you have an association with slower passage of thiopental from the central to the peripheral compartment. It basically results in a higher plasma concentration available for distribution into the brain and a greater effect. So in increasing age groups, you got to reduce your dosage. Decreased dose of thiopental is required to flatten the EEG in the elderly as well, so you don't need as much. So in elderly people, you have to give less. In pediatric patients, a lot of times, you have to give more, just like many of the other anesthetic agents that we deliver every day. Clinical uses of barbiturates. Their principal uses are induction of anesthesia all the way to the 1980s. We use methotrexate from electroconvulsive therapy, which is ECT. We used to use these agents a lot for ICP control, because it decreases ICP. Also, we can use the thiobarbiturates and some of the other barbiturates as long as they don't have the methyl group attached to it as for control for seizures. Phenobarbital was very helpful and continues to be helpful in controlling seizures. And one of the things that also used in the 1950s, 1960s, to control hyperbilirubinemia in infants was giving them phenobarbital, because it actually will induce the enzyme to break down bilirubin. Okay? Now that's almost never used. Instead, we're using lights like this. So it's more of an anecdotal history again. The drawbacks is a lack specificity and effects in the central nervous system. They have a, and we'll show you next hour when we talk about barbiturates, benzodiazepines, about how they're more effective. The benzos are. They have a lower therapeutic index, which means that they're a little bit more dangerous. They're in tolerance of more easily than benzodiazepines, so they're tolerated more easily. Have a greater liability for abuse. It's one of the downsides. They have high affinity for other drug interactions. And in some people, they actually get paradoxical excitation, especially in the elderly. But that's only if you give really small doses. The induction doses that we're giving are not this issue. This is where you see people that are getting PO, barbiturates, you see that problem. The other thing that's really a problem with barbiturates is that when you give it in really small doses to somebody who's in pain, you can accentuate the pain. You can make it even more excruciating. And I saw that happen to in a trauma patient. Somebody was giving like a small test dose of barbiturate, the barbiturate thiopental. I looked at him like, what the heck are you doing? And before, we actually could realize what was going to happen next, was the guy sat up and started screaming at the top of his lungs. So it's very good at decreasing the pain threshold and making the person really have very, very a lot of pain. So it seemed to push away the opiates. And of course, it didn't push the opiates. It just sensitized the brain to activities for some reason. It's not a very effective sedative in the presence of pain, which I just was talking about. And the hangover effect is a real downside to it. And it doesn't have, even though the book says it has some muscle relaxation, it doesn't have enough skeletal muscle relaxation to be effective clinically to be able to use it at all in the operating room. When you use thiopental, it was the only exclusive induction agent prior to 1989. What we would do is we'd give 3 to 5 milligrams per kilo. Okay, so we'd be giving 400 milligrams to people at times. Okay, and that was your normal induction dose. It had a very rapid onset. You could set your time on it. And the other thing you would tell patients is you tell them it's going to taste like garlic pizza. This would be my line of telling people to sleep. And here comes the garlic pizza, and they would taste the garlic. They would tell you, I tasted garlic, and then they'd fall asleep. Okay, so they would actually remember that afterwards. The other thing is because the alkalinity is so high, the pH is like 10.5, it burns on injection unless you have an enlarged bore IV. So a lot of times we went for the large IVs as much as possible in these individuals and increase your flow rate on your IV to make sure that it doesn't stay concentrated in your IV line. It may cause profound hypotension in hypovolemic patients, so we would reduce our induction dose down to 2.5, 2 milligrams per kilo. The redistribution was very, very consistently there. At around 8.5 minutes, people would start waking up. At around 7 minutes, people would start moving around. At 8.5 minutes, they were opening their eyes looking at you. It was very predictable. And this is a perfect drug when you combine it with succinylcholine. When you give the normal induction dose of succinylcholine, 1 milligram per kilo or 1.5 milligrams per kilo, they would wake up and be moving at the same time. So you would get both the medications and effects going off at the same time. Now, rarely used to maintain anesthesia due to long context-sensitive halftime, and basically is contraindicated in somebody with acute intermittent porphyria. Everybody forgets this part. Okay, I had one kid who came in to Tampa General where I was working, and 2 times before he'd been hospitalized, he had been put in the intensive care unit. This is a 26-year-old boy. And I looked at him and said, okay, this sounds funny. So I grabbed a chair and sat down and started talking to him for a long period of time. About an hour later, I said, this guy's got a weird story. He's got these severe abdominal pains that keep coming and going. Can't really explain it. Okay, nobody's been able to explain it. Every time he would go to sleep, he would go into profound shock and would stay intubated for 48 hours. And then after 72 hours, miraculously get better, the abdominal pain would go away, and he'd wake back up. You figure this guy's nuts, right? But what he actually had was acute intermittent porphyria. And it's kind of cool. I got to tell him, I said, I think I know what you have. So we sent him off to the lab, and he got tested, and sure enough, he came back with acute intermittent porphyria. And we did the next induction with Diprovan, and he had no problems. But you give these people salbutamol, you put them in a metabolic crisis and push them into a porphyric attack. What is acute intermittent porphyria? It's a rare autosomal disorder which affects the production of heme. And you'll talk about this when we talk about coexisting later on. We'll go all into the different forms of porphyria. But the one that you have to really know for this test is acute intermittent porphyria. These people have abdominal pain, which is very severe and poorly localized. And these people get operated on. This is why this kid had been operated on twice. And they found nothing the first 2 times. They'll get operated on for abdominal pain. They think it's got some kind of a small bowel obstruction or something. And then when they get in there, they find nothing. And that's what they had done. And this guy was coming in again for the same thing. Urinary symptoms is they get dysuria. And then what actually tipped me off that something was going on is that his urine changed color all the time. He said he would feel bad at certain times when his urine would turn colors. And the reason his urine is turning colors is because bilirubin is a metabolism that requires to go through the urine, and that's what makes your urine stain this color that it is. And if you change the metabolism of bilirubin, then the actual urine concentration changes of that pigment, and you can get differences in colors. So you can actually get more like a purplish kind of urine, which is kind of interesting. Barney color urine, but oh well. You get peripheral neuropathy, and the person develops proximal motor weakness, usually starting in the upper extremities, which can progress and include respiratory impairment and death. This is what happened to this kid. When they give him thiopental, it caused him to develop severe muscle weakness, and then they couldn't extubate him. So actually, if you looked at the chart, they kept saying weakness, residual muscle relaxation. The twitch response was perfect, but still the person appears weak. They didn't put it together. Okay? And then what you have is autonomic nervous system. You get dysfunction, you get tachycardia, hypertension, sweating, restlessness, and tremor. And these people develop neuropsychiatric symptoms where they get agitation, hallucinations, delirium, hysteria, and depression. Who is this man here? Do you know? That's Van Gogh. Okay? Vincent van Gogh most likely had acute intermittent porphyria. The other person that also most likely had acute intermittent porphyria, and the reason that we're in the United States right now is because of this man, is King George. King George of Britain, during the Revolutionary War, kept having these attacks of craziness. And because of that, they think that is why the Americans ended up getting away from Britain, because simply he wouldn't address any of the problems. He was completely erratic as a leader. It wasn't that he was a bad leader, it just that he had disease, and they didn't recognize it. Okay? They would say that he had royal purple urine, so he was truly a royal. So pretty impressive. And they noticed it, but they didn't know what it was. It was before I really understood metabolism of different things. And a lot of times these people will get hyponatremic and lead to seizure activities. Okay. So let's keep moving along. Talk about this for about 20 minutes, and we'll finish up and then move on to the next subject matter, which is benzodiazepines. Methotrexate, which of course is a barbiturate, but it's an oxybarbiturate, was used and is still used in clinical practice for a treatment called ECT, which is electroconvulsive therapy. I know it seems kind of brutal when you hear about it, but it actually works. People that are almost to the point of catatonia and severe depression, where they have severe suicidal ideations, once you do ECT therapy, I've actually seen people recover and actually leave the hospital and have very productive lives. and then they come back and get retreated again about 7 or 8 years later. What we're basically thinking the way it works is that we induce a massive seizure in the individuals, and it resets the brain's electrical activity to a more normal activity, and then the person comes out of depression. Now, what ECT's downside to it is that you are causing a severe seizure. I mean, it's dramatically how bad the seizure is. You can actually see it on the EEG, showing you how significant the actual seizure is. And you want at least a 30-second duration of seizure activity. The way we actually would do it, where I was trained and in Chicago as well, and we used to do it here before. We had one psychiatrist that would do it. We'd take about 4 or 5 patients, and we'd do it around 6:30 in the morning and get them all done before the 7 o'clock, 7:30 starts time for the rest of the cases would start. And that's pretty much everywhere you do it. Every day, every time you start these, you usually have like 1 or 2 days a week, and you have everybody lined up. At Northwestern, we used to have almost like 16 people, and we had 3 residents and me being one attending, and we put everybody to sleep, and we'd be done in about an hour with all 16 people. So it's really quick and rapid. So you want an induction agent that's fast, okay? You want also an induction agent that prolongs the seizure activity. What prolongs the seizure activity is 2 things. The drug, okay, and the second thing is hyperventilation. The reason hyperventilation is so critical is that if you drive the CO2 levels down by hyperventilating, it takes longer for the CO2 levels to rise high enough in the brain to stop seizure activity. That's how actual seizure activity stops. It's hypercarbia. Okay? When people are having seizures in front of you and they're actively seizing, what terminates the actual seizure activity will be the hypercarbia. So if you try to hyperventilate those individuals, you're actually doing them a disservice. Just, if you need to, give them oxygen, that's fine, but then just wait till their CO2 levels build up and then the seizure will terminate. If you have medications, give that, of course, first. Now, the danger of course, this high-level seizure, and there's been reported cases of it, is vertebral fractures. Okay? So you can actually break your back when you're doing these. There's been long bone fractures as well from spasms of the muscle. So what we do with these people is not only do we put them to sleep, but then we also administer them succinylcholine. So we administer 2 agents, an induction agent and a muscle relaxing agent. And you got to check your twitches, and you have 0 twitches before you fire somebody up. If you have not 0 twitches on this individual, you will find out the bad way what can happen. Okay, so you don't want to do that. So now, what you want to have is you want to have a drug that they wake up in the same profile, and succinylcholine has the same profile time, which is around 7 minutes. It is off your system as long as you stay under the 1.5 milligrams per kilo, with methotrexate also at 1 to 1.5 milligrams per kilo. And then the person will wake up smoothly. You do have to ventilate them through the whole time, of course, and hyperventilate them. So it's actually a very, very predictable agent. This, actually, you see right here, see that bite block? That's to protect the teeth so you don't break the teeth when they seize. Even though you have the person completely muscle relaxed, the actual inducer of the seizure is an electrical paddle they put in the side of the head. Well, it's so close to the masseter muscle that it actually will cause it to fire, even if you have it muscle relaxed. It'll overcome your succinylcholine. So you'll see a person break all their teeth if you don't put the bite block in. So everybody gets a bite block right before you put them to sleep, before you seize them. You can see the band on the person's head. That white band is actually, this white band here is basically to put the electrodes that sense, and this device is what actually induces the seizure activity here. This big little paddle. They put it one on each side of the head. They fire you up. Okay? When you see it, it's actually kind of Frankenstein weird. But when you actually see how much the person benefits from it, it's actually pretty impressive. The other thing you will see methotrexate be used for is for temporal lobe resection of seizure-producing tissue, because you want to see when you're doing the mapping that you don't resuppress seizure activity, so that way you can know what areas to resect. The undesirable effects is that high doses are associated with seizures in approximately 1/3 of patients post-op. That's a real downside. Okay, but that's if you go into high doses, and we don't go to high doses. We stay at the 1 to 1.5 milligrams per kilo. The high doses are around 3 milligrams per kilo. So you really should not give a repeated doses of methylhexatol. It's really not smart. There's also increased incidence of excitatory phenomena with involuntary skeletal muscle movements and hiccuping. You get myoclonus when you give the medication. It almost looks like etomidate. Etomidate does something very similar to this drug, but you tend not to see it when we're doing ECTs because we're following immediately with succinylcholine. So we don't see that effect that much. The incidence is dose-dependent and can be decreased by premedication with opiates, which we never do in ECTs, and optimum doses of methylhexatol. Really, you should use lean body mass and go use the 1 to 1.5 milligrams per kilo dose. Potency, relative potency of barbiturates for IV induction. Thiopental is the most potent. Right next to it is very close is thioamylol, and barbiturates. Sorry, the most potent is methylhexatol, which is 2.5 times the relative potency. And thiopental is a weaker of these agents, but I'm telling you, thiopental has very impressive how it puts you to sleep. An increase in potency for methylhexatol is due to lower ionization at physiologic pH, but the actual duration of action is pretty short. Now, what do you also use these agents for? Just to treat for elevated ICP. But unfortunately, even though you can treat all these things, there's really no benefits of barbiturates used not to improve outcomes for head trauma patients. So we used to do this a lot. We used to give people, we'd put them in a barbiturate coma, and people didn't seem to have any difference in benefits, even though you had lower ICPs. I think part of that reason is because you can't change the primary damage. Whatever the primary damage is, that's, you're going to suffer the consequences of that. The secondary damage is what you're trying to avoid, and the barbiturates do help in decreasing the ICP for that reason. And the way they do it is by they cause cerebral vascular vasoconstriction. They also decrease cerebral blood flow, and they cause decreasing cerebral blood volume, which I think is a problem at times because if you're too aggressive with this and you don't get adequate oxygenation because you're not getting adequate cerebral blood flow to the brain, you may actually causing more secondary damage. Okay? The other thing that is associated with, of course, treating elevated ICPs, we hyperventilate patients, and it seems that we work just fine with barbiturates, and of course, diuresis. Okay? The barbiturates not only decrease your actual cerebral blood flow, but they also decrease your cerebral metabolic rate of oxygen consumption, which is a good thing too. So it does it together. Hazards are hypotension associated with high doses can decrease cerebral perfusion pressure to critical values. And that's really, I think, maybe the downside to this drug. It's also a venodilator, so it can preload reduce you quite significantly, and it can decrease your cardiac output. And what you see is the doses of barbiturate required to suppress EEG activity results in vasodilation and myocardial depression, very similar to isoflurane. So it can have some bad effects. And barbiturates may be preferable to isoflurane if profound EEG is desired. We can actually induce EEG isoelectrics with barbiturates. Pretty commonly done, okay? But you have to use pretty high doses of it. You can't use the normal 3 to 5 milligrams per kilo. You're looking at 15 milligrams per kilo of sodium thiopental. So you almost have to give triple the amount of normal dose. And where do you use this? Well, we would when you take a patient and you put him to sleep for a aortic root repair, okay? And you're going to put that person in a complete cardiac standstill, and you're not going to be able to perfuse the brain because you can't put a cannula in the upper portion of the aorta or in the carotids. So these people are going to have no blood flow to the brain for as long as 45 minutes. So in that situation, you want to do two things. You want to make them hypothermic as much as you can, and usually what we actually drive them down to is 17 degrees Celsius. At 17 degrees Celsius, 90% of the brain is isoelectric. The problem with that is your brainstem is still not isoelectric because it's still not cold enough. So what you can actually add to suppress the system even more is you add barbiturates, so like sodium thiopental. That's how we would actually pull. That's the only time we really would pull out the sodium thiopental anymore, You'd pull it out and give like 5 vials of it. Okay, so you're looking at, I don't know, 3,000 milligrams, 4,000 milligrams of pentothal. And you would make that person completely isoelectric at that point. And that will keep you isoelectric for at least, let's see, 2 hours. So the downside to it, of course, is now that person's not going to wake up right away. It could be up to 24 hours before the person would wake up. And that would be, of course, stressful for everybody because everybody wants to see the guy wants to, is he going to wake up after this? Because if you, that's one thing you do want to know as soon as possible. The downside to it is none of the studies ever showed that it makes a difference. We do know that it's isoelectric, but does it make really a difference? I took care of somebody about a year ago where we actually had run out of sodium pentothal, couldn't get any more. Put him to sleep. The way we actually made him isoelectric was we drove up the fluorine levels up to very high levels and made him isoelectric that way. Okay? And he woke up the next day and he was actually eating lunch when I came by, eating steak, which was really impressive. I was extubated and doing fine. So that's something I wasn't used to because usually when we're giving the barbiturates, they wouldn't wake up until at least 24 hours later. Yes? We were thinking about what do we have available, okay? Some people would use benzodiazepines, but benzodiazepines don't make you isoelectric, okay? So that doesn't really work. So only barbiturates really work. So fluorine will also make you isoelectric. So that's what we did at the time. It seemed to work. And the way we actually monitor, this is, of course, late in the afternoon because all these cases never come in the middle in the morning. They always come in late in the afternoon. And so we had no EEG monitoring. Instead, we used BIS. And when he gave enough fluorine, the BIS went to 0. And we pretty much know that the person's isoelectric. And then they made him cold after that, too, so to add 2 effects. The good thing about the gases is once you shut them off, it comes out through your lungs, and then it comes down, and then the person wakes up. So he seemed to do well, actually. So he was a very lucky guy, 47 years old, and decided to prove to his 18-year-old son that he was still a 19-year-old boy, and 350 pounds of chest press, and ruptured his aorta. Quite impressive. So, and he actually walked away. That's even more impressive. So, cerebral protection. Barbiturates have not improved brain survival in cardiac arrest patients. That's where the issue is, what I was telling you about before. The routine use of barbiturates during cardiac surgery is not recommended due to increased need for inotropic support and really prolonged recovery time. And actually, hypothermia may be more protective without the prolonged recovery. And I believe that, too. Hypothermia has been used since the 1930s very effectively to protect people's brains. Where I actually got really interested in this was when I saw people drown in Michigan, up in Chicago, and what's the name of that lake? It's not Lake Michigan, is it? It's Lake Michigan? Yeah, okay. So I had somebody drown, had been underwater for 55 minutes. We pulled them out of the water. His actual body core temperature was, I think, 16 degrees Celsius. And it's like, wow. I'd always read in the book that you can't diagnose somebody dead until they're warm. So we proceeded to do everything we could, and we actually put him on bypass machine to start warming him up, because what he kept doing is that he kept trying to die on us. Every time we'd bring his temperature up to 19 degrees, he would fibrillate. So after trying for about 4 or 5 times to rewarm him just normally, we decided to heck with that and put him on bypass, and then pushed his temperature through the 19-degree threshold, got him out of the V-fib, got him up to 21 degrees, and then we took him off slowly and bring his temperature back up. And the guy woke up and was completely intact. He was underwater for 55 minutes. That's pretty impressive. Okay? It took him about a week to recover his lungs because his lungs were full of water. That's how long he was drowning, so that's pretty impressive. Most people that drown don't have water in their lungs. You realize that? Most people, when they fall in the water and they drown, their larynx closes up completely. Okay? And when the larynx closes up completely, it doesn't allow any water in your lungs. It's only several hours later, or about an hour into when you're really dead, that the larynx will open up again. Okay? And this guy was pretty dead because he had water in his lungs. So But he actually survived it. It's pretty impressive. And now we're actually doing, if you're interested in hypothermia, they actually bought a new book. It's in the library that talks about hypothermic treatment for cardiac arrest patients. We're taking patients that have had a cardiac arrest that are not waking up right away and inducing deep hypothermia and keeping them that way for about 24 hours, and actually helps protect the brain. And these people tend to wake up better. They have better neurocognitive results as a consequence. So it's a pretty interesting area of research that people are doing actively right now. The side effects of barbiturates is they cause significant cardiovascular depression. Mostly of it's venodilation, so it decreases in preload. So you get transient drops in blood pressure. It's usually as a consequence of this venodilation, you get a compensatory increase in heart rate. So you usually see a 15 to 20 beat increase in heart rate in normal bulimic patients. In somebody who's significantly hypovolemic, the tachycardia will be more severe, but a lot of times will not overcome the drop in preload enough, and the person will develop profound hypovolemic shock. It also has some direct myocardial depression. It may also occur with overdoses or with large doses required to lower ICP, which is a downside to it. So now you have a decrease in contractility as well. You also have a mild and transient decrease in blood pressure due to depression of the medullary vasomotor centers in the brainstem, and due to decreased sympathetic nervous system outflow, leading to significant peripheral vasodilation. Most of it's venodilation. 90% of this is not sympathetic, it's not the arterioles, it's really the venous system that's getting affected by barbiturates. The other thing that you'll see is histamine is a big problem. Histamine, especially with thiopental, about 1 in 30,000 patients get a very severe histamine release, and you have to give them aggressive treatment with IV fluids and epinephrine. The Benadryl won't work. You'll see this urticaria rash that develops all over the patient, and then you get profound shock, and you have to give them epinephrine. You can't. So for this reason alone, this really makes this agent kind of dangerous. For every one out of 30,000 cases that you're going to do, you're going to get into this kind of issue. Propofol doesn't have this issue. Again, another benefit of this new drug. What kills most people with thiopental in the past was hypovolemia, hypovolemic shock. In hypovolemic shock, what ends up happening is that your sympathetic nervous system cranks up. It increases your vasomotor tone, and it affects mostly the venous side. It begins to compress your venous side to try to push more blood into your central circulation and getting it back to your systemic circulation. So when you give barbiturates that are profound venodilators, you get a significant dilation, and then now you have no preload return back to the heart, and the person can cardiovascular collapse on you. The way you know if something bad's happening is the heart rate all of a sudden zooms up, and you lose your pulse oximetry, and you feel your pulses, and they're gone. Not a good thing. That's not a histamine reaction. That's you put this person under shock, and you gave them pentothal. Not a good thing. And this is what actually happened in World War II until they figured out what was going on. Okay? Beta blockers and also centrally acting alpha-2 agonists also accentuate this response. So things like clonidine can give you a very profound shock state in beta blockers in these patients. The reason these people can compensate for decreases in preload is usually it increases in heart rate. So if you give people beta blockers, you basically inhibit the actual normal response to this venodilation, and you get more profound shock. Ventilation. Barbiturates will stop your breathing, and they work at the central medullary and pontine ventilatory centers. Leads to a low response to hypercapnia and low breathing rate and low tidal volume. So this is a profound effect on your ventilation as it decreases both your rate and your tidal volume. If you give other CNS depressants, like if you have alcohol on board or you have benzodiazepines on board, and you give somebody thiopental, you get a very significant synergistic apneic effect. Okay, and you always have to be ready when you're giving barbiturates to somebody that they'll stop breathing. You've got to be really careful with these drugs. Laryngospasm may also occur with inadequate depression of the laryngeal reflexes during intubation attempts, so you cannot place an LMA using barbiturates, which I told you about before. Effects on the kidneys, there's a modest decrease in renal blood flow because, again, you're venodilating. You have a decrease in GFR, and that's mostly due to decrease in blood pressure and cardiac output. There's histological evidence of renal damage is not detectable with these drugs, so these drugs really don't cause any effects to the kidney in the sense of structure. They just basically affect the kidney's blood flow, basically because it affects cardiac performance. On the liver itself, thiopental produces a modest decrease in hepatic blood flow, but induction doses don't alter postoperative LFT, so you're basically not doing liver damage with giving thiopental. Liver P450 induction barbiturates stimulate the liver metabolism after 2 to 7 days of sustained drug administration. So when you give somebody long-term barbiturates, which they used to use for sleep, phenobarbital is the most potent enzyme inducer of all the barbiturates, which is used for seizure activities. So you can expect that if you give that person somebody that already has phenobarbital on board, it's going to take a lot more to get them to sleep. Okay? This stuff really works. Barbiturate induction will accelerate the metabolism of lots of things. It'll affect the anticoagulants, phenytoin, tricyclic antidepressants, corticosteroids, vitamin K, and birth control pills as well. Yeah, well, Pentothal, we used to give it all the time for women. It actually was a preferred drug all the way until recently. And now we're forced to use propofol, which has really not been adequately studied in women. But that's all we have, so we're stuck. So in the old days, we would always, when you heard that somebody was pregnant, you would pull out the sodium thiopental, because that was a drug that you knew that was essentially safe to the baby. Okay? The barbiturate readily crosses the placenta, but in fetal plasma concentration significantly lower than maternal plasma concentration, so it has less effect on the baby. And as long as you keep up the doses of 4 milligrams per kilo, probably do not result in excessive concentrations in the fetal brain. And they've really never been, anybody who's gotten sodium thiopental while they were pregnant, it didn't seem to have any kind of effect on the baby long term. So that's a good thing. Tolerance and physical dependence. You get acute tolerance occurs earlier than enzyme induction. So yeah, tolerance is maximal. The required effective dose is increased up 6-fold. And tolerance to sedative effects occurs sooner. And it's greater than the anticonvulsive effects and lethal effects, which is not a good thing. So when you want to sedate somebody with these drugs, and you're not getting the effect, and you keep upping the dose, and what you end up getting is getting to the dangerous effects of the lethal sides of it before you actually get the sedative effect. So you narrow your toxic range. So tolerance to the sedative effects increases, the therapeutic index decreases, which means that the person increases the risk of dying from these drugs. And that's what you saw, overdoses of these drugs after a long-term treatment. This is really sad. This is something you've got to be really careful of. Pentothal, because any methotrexate, because its pH is so low, so high, so alkaline, it's 10.5. When you give it intra-arterially, it almost immediately crystallizes. Okay? Not good. And when it crystallizes, it goes to your end digits, and you get this effect. This person is going to lose all these fingers. This is also another person. This person had an arterial line on this side, a radial line, and the person injected the sodium thiopental in the arterial line. Don't ever do that. Okay? And trust me, I've had people put something on an arterial line, and I had to tell them to stop. So it can happen. Okay? What I personally do is that when I use any kind of arterial line, I put on a red cap at the end of it, or I make sure that whatever the cap is different than any other caps that we're doing, and then I label it, usually tag it as arterial, so people can't make that mistake. When people get in a rush, they grab the first IV they see, and they start injecting through it. Okay? I've seen nurses inject TPA through an epidural catheter because they thought it was a central line. Okay, so if you think that's not possible, people make mistakes every day. Okay, so this is a devastating complication. They get intense vasoconstriction. Usually you'll know it if the person's awake when you inject it because the person will scream in pain. If you don't treat it appropriately and aggressively, the gangrene and permanent nerve damage will result. And risk increases with increasing your drug concentration that you're giving. So if you shut it down fast, you realize your mistake, and then you start trying to treat it, then the person may have a chance. How do you treat it? That's the actual mechanism. The mechanism is actually precipitation of thiopental crystals. And then you leads to an inflammatory response which causes clotting inside the blood vessels. The treatment of accidental intraarterial injection with barbiturates is an immediate attempt to dilute the drug. So what you want to do is to start hooking up your saline and start flushing continuously with saline through the artery. Just keep flushing it. Hopefully you'll flush out the crystals. Is also maintaining the blood flow. And what happens initially is you'll see intense vasoconstriction. The hands will turn white on you, okay, because the vasoconstriction is so severe. So what you have to do is you have to inhibit that as fast as you can. The way I've seen it work really easily, worked real fast, we drew up 5 cc's of lidocaine, of 2% lidocaine, neck, stellate ganglion block, put a needle in here, injected 5 cc's, and the arm immediately vasodilated. You see the whole arm just flushed, turns red, the hand vasodilated, and we were able to flush out that medication. And the guy didn't have any problems. Got lucky. Okay? But somebody got in a rush. It wasn't me, thank goodness, but it was still scary to watch. Okay? So lidocaine in which is called sympathectomy, using the stellate ganglion block, is very effective. If you want a more prolonged effect, you would put an axillary line. So you do an axillary block. The axillary block will cause vasodilation for up to 24 hours. And if you want to put a continuous catheter, you could continue doing that for up to 48 to 72 hours. That's what we used to do for reimplantations of arms and limbs. The other thing that you also get is you can also get venous thrombosis with this stuff, but it tends to be less of a problem because as you inject it into a vein, the vein gets bigger as it goes further away, versus an artery narrows down and the crystals tend to form in that area, versus if you put it into a vein, the further away it goes, the veins get bigger and the crystals are able to dissipate. It's less hazardous because of ever increasing diameter of the vein, and it's basically to try to keep your dilutional concentrations down, which is like the 2.5 for pentothal. They used to come in the 5% thiopental, which is very, very potent. People were trying to save money on the IV solutions, so we would try to make it a more concentrated solution. And it's not a good idea because it's a lot more painful in injection. You get more crystallization to take place. So you really want to use the more diluent solutions. If you have allergic reactions, what do? You have to give them pretty quickly epinephrine. I give IV epinephrine usually at that point. You get a very profound shock. Sometimes you will actually... and so an anaphylactic reaction requires that you have what? You have to have had exposure to this medication before. Okay, because what it does is it forms antibodies to that medication. It recognizes that medication is an antigen, a foreign antigen, and tries to attack it. But you can give somebody pentothal for one dose, one time, and actually get a reaction that's profound. And that's not really an anaphylactic reaction. That's called an anaphylactoid reaction. Okay? Some people are genetically predisposed to have problems with pentothal when you give it to them. Okay? So anaphylactoid reactions are not really truly allergic reactions because you don't have any IgG or IgM sensitized, but it still results in histamine release, venodilation, wheals, and welts. So it appears to be it, but when you ask later on that individual, have you been exposed to pentothal before, and they tell you no, then that's an anaphylactoid reaction. That person is genetically predisposed to that. So what you have to tell them is, what? Your family most likely will have the same reaction. So if you have somebody with an anaphylactoid reaction genetically, that rest of the family tends to have a much higher risk for developing that same kind of reaction. Now the last thing is on neutrophil function. This is one of the reasons that we try not to use it in cancer patients. We didn't like this drug because it's an immunosuppressant. It actually decreases the neutrophil activity and impairs its function. So it increases the risk for developing bacterial infection. But it's a great drug if you're trying to use it for transplants. And actually, it was a preferred drug in my day when we were doing kidney transplants, liver transplants. That was the drug we used for induction because it actually suppressed the immune system and began to immunocompromise you, which is a good thing when you're doing a transplant.